Good afternoon. Thanks everybody for inviting me and give an opportunity to present the work I'm doing. Not by myself, definitely. It takes a big team to make progresses, and I'm going to talk to you today about our work with the International Consortium, but also the work that I'm doing in California that also helps and complement the two approaches. So let's start with the Childhood Leukemia International Consortium. And the idea behind is childhood leukemia is rare, and that's the good news, but it's challenging for everybody in each institution to really try to make progress when they study leukemia. So the idea to bring together researchers is to help to bring more power to study what causes leukemia. But I would like to start with thanking our funders, because the reason why we are still here, the Childhood Leukemia International Consortium is still here after 10 plus years, is that we were fortunate to have funding throughout those years. And Children with Cancer was one of our first founders who believed in the project of working together. And I wanted to thank them definitely today. They were very critical for us to get started. But it took also other funding from agencies in the US, but also a private foundation in the United States as well, to help us carry on the consortium through the years. This is even not talking about the motivation and the resources that every site is bringing to the table. It's pretty much a work from your heart. A lot of people are working without any additional funding, but they believe in the work that we do together, and they help us to be successful. So definitely a big thank to our support throughout the years. The mission, as I said, of the consortium was trying to accelerate our understanding of what causes leukemia. And what we really wanted to do is establish a group that would be comfortable to work together without any fear of competition, because we do live in a competitive world when it's time to get grants, but we wanted to really break those barriers and work together and share ideas. And we want to give an opportunity to young investigators to start working with us so they can actually carry the baton when most of us won't be around to continue the journey. So, as I said, the idea started back in 2005, and one of the first meetings was at the International Agency for Research on Cancer at Lyon, and that was the first time that we really brought together around the table a lot of researchers, and we were trying to figure out what would be the logistic for us to move forward. And although the meeting was done at IARC, we pretty much came up with the conclusion that there was already a lot of studies done, and that we could work together, and we were not formally, working under the umbrella of IARC, or we were not formally working under the umbrella of the National Cancer Institute, which gave us a lot of freedom and independence. So, the price to pay was to seek our own funding to still be here, but, to the benefit is to keep independence and flexibility in our research. And the group evolved throughout the years. We officially started the consortium in 2007 with 2 projects as a proof of principle, and that was an opportunity to establish also our procedures to share data. And as of today, we have about 40 studies in about 18 countries, so the consortium has grown quite a lot. So in terms of, this is the map of the consortium. You can see that we have pretty good representation in Northern America and Europe, but we also have several studies in Latin America. We have a few studies in Oceania, and we don't have a good representation in Africa and Asia, but we're working towards that. So what are the numbers? We said that childhood leukemia is a rare disease, but by working together, we are able to bring data for about 40,000 cases of childhood leukemia, which is a lot. We bring many, many more controls, and the reason being is that we have a mix of studies that are studies that were just designed to study childhood leukemia with enrollment of the patient and the families. And we have studies that are using a linkage with their own database from the cancer registries and other linkage, and those studies tend to bring a lot of data pretty fast. However, the quality of the data and the type of data is different. So, but we have a total of 40,000 cases, the majority being ALL, but we also have a fair amount of children with AML, which is a much rare subtype. So the reason why we could get started to work together is that most of those teams actually were looking at the same usual suspect, same risk factors. So there was some comparability between the studies, so we could actually start working with everybody pretty fast. And the common factors were, SCS factors, birth characteristics, mother and child's health, exposure to chemical at home, at work for the parents. So there was some analogy in the type of data that was collected. There was less data available for diet, for example, for EMF. We talked about that, so we have not made as much progress on that. And of course, the other side of the research that we're doing is to look at the genetic component of the disease. And there's also data in the CLIC consortium that now have genome-wide data when the early studies had what we call candidate gene data. So we have a pretty rich set of data. And of course, not one study will use the data from the 40,000 cases. It's always a mixed. We use what we have available and what the studies want to contribute to. So to make the consortium successful, it was very important to be transparent and to establish procedures. Investigators in each team felt that it was really something they wanted to have in place before sharing data. So it took us several years to really work through our own protocol using some framework from other consortium, but also just establish our own rules to bring an idea to the consortium, have a request for a proposal that is being reviewed by all the investigators in the consortium, that is then approved or not, or amended, and then we can initiate the transfer of data and we can start pulling the data. And we also establish procedures in terms of having what we call a working group, which is a set of 3 to 5 investigators that are working closely with the PI that is pulling the data. So there is some additional support throughout the process before it's being presented to the larger group. So those procedures have worked pretty well, and I would say since the last 10 plus years, when the consortium started, we have analyzed a lot of data. This is the list of publications that we have today that goes from birth characteristics to occupational exposure for the mom and the father, intake of vitamins and folate, mode of delivery, having a child born through C-section or vaginal delivery makes a difference, and this is related to the immune priming of the newborn. So this is the list of the analysis that we have completed and published as of today. What I would like to do just briefly is to point some of the analyses that are really taking advantage of having original data. Why would we go through the effort of pulling original data when I think maybe every day you have a meta-analysis that is being published on any topics? So why would you go through the extra mile to actually work with the original data and work with the PIs? And this is where I'll give you a couple of examples. I'll start with exposure to paint at home. And there has been some hypothesis that the etiologic pathway may be different according to the type of leukemia. And leukemias are defined by histological subtype, AML, ALL, but also molecular characteristics like translocation, deletion. And we believe that the same way the leukemia type has different response to treatment, that may be an indication that they have also different etiologic pathway. But to look at those subtypes needs collaboration with others. And that's an example of that study where we looked at childhood ALL with a different chromosome characteristic, being extra chromosome like high hyperdiploidy or translocation or MML rearrangement. And you see the numbers of studies start to slow, to actually be quite small. We had 3 studies that have this type of information, but this is better than 1. And here we could confirm that leukemia that have chromosomal abnormality, structural abnormality, have a highest risk of being related to exposure to pain. So this type of analysis can be done with more robust finding with the CLIC consortium. Another example is to study acute myeloid leukemia. I told you the numbers are pretty small when you look at one study at a time. Here we were able to pull data from several studies here that you see on the map. And then we could have a sample size of about 1,300 AML, which is, again, unheard of. And we looked at this data in relation to tobacco exposure. And what we could do here is that, in general, it's a puzzling finding, but we have not been able to find association between maternal smoking during pregnancy and childhood leukemia in general. However, when we run the analysis here with the consortium and were able to look at different racial ethnic groups, we could find that actually there was an increased risk in the mothers of Latino background. So that was the first time that we were actually able to identify a group that had an increased risk of childhood AML. Regarding the fathers, in terms of exposure to tobacco smoke, findings have been more consistent that exposure, when the father reports smoking before pregnancy or after pregnancy, studies have found that there is almost a 20% increased risk that you find here at the bottom of this first graph. But pooling actual data allows you to do a dose-response relationship. And again, this is the advantage of the CLIC consortium. And here you could see that the heavy smokers were more likely to have a child who would have leukemia compared to those who were not smoking as much. So this type of analysis is feasible with a rare disease when you actually have the data in hands. Another example was when we looked at prenatal supplementation with vitamin and folate. And this is, the map of the studies that contributed to this analysis. We did this analysis for ALL and AML. But one difficulty, for example, when we want to study this in the United States is that over 90% of the women do take vitamin supplementation during pregnancy. So for us, there is no variation. We cannot really we cannot really address this question. However, when we work with the consortium, here we bring a lot of variation in exposure. And you can see, for example, from the left side of the graph here, which is the prevalence of vitamin supplementation before pregnancy, you can see that countries like the US, Australia, have a high percent of women taking these. However, this is not the case in many studies in Europe. And here, this is the prevalence of intake of vitamin during pregnancy. And you can see, again, a lot of variation. So here we can take advantage of the geographical variation and look at this question. And what we found is that whether we look at any intake of vitamins preconception or during pregnancy, or specifically folic acid, we found that there was an overall decreased risk of childhood ALL. Here you see the odd ratio is below 1, statistically significant. What we were able to do with the original data is to stratify this analysis, and the idea was to look at mothers with lower education as maybe a marker of not having a baseline folate levels, adequate folate levels. So when we did this analysis by education, we found that the reduction in risk was the most profound in those women who had low education, when the benefit was actually not there for the women who had high education. So that helps us to target who should have prenatal vitamin supplementation. We should target those women who don't have a good baseline level of those vitamins at the first place. So those were examples of data that we published, again, that is available to us, so we can do more refined analysis. We have more studies underway here, looking at family history of cancers, which is rare. So again, working with a consortium will be helpful. We are working on maternal infection, medical radiation. More and more children are being exposed to CT scan, and this is an opportunity for us to work with our consortium. We can focus on very rare disease subtype like infant leukemia. Definitely, this analysis would benefit from pulling data from the consortium. And we're still working, throughout other occupational exposure. In terms of genetic analysis, I think we're just getting there. We're just starting to be able to pull data and to maybe do a better job at looking at gene-environment interactions. So this is, that's going to be our near future, to really try to work with genetic data, which we haven't done yet. So, in conclusion, I think it's important to work together and to bring data from a lot of studies. I think it helps to kind of put the compass in one way or another. We understand there's heterogeneity. We understand there is a lot of differences that could lead to different findings individually. But at the end of the day, it helps us to tell, well, there is an excess risk, or there's a no excess risk, or there's a reduced risk. I think this is still helpful for us, all things considered. And this type of data are really important for prevention. We need to have some kind of confidence in what we are saying, and colleagues who are working in getting the message out are really relying on this type of information that we generate from the consortium. So, of course, the strength is our people are really motivated. We have a very diverse group of scientists to work with. As I said, the data are diverse. We are able to make the best out of every single study that has been done with robust design. We can adjust, for confounders. We can look at effect modification, things that you cannot do when you just work with published data. So we're using published and unpublished data from those studies. Of course, this comes from challenges. I will not ignore the fact that we are still dealing with data harmonization and that we lose precision when we want to combine data. As I said, the genetic analysis have been way behind, but finally, we're kind of catching up on that. Our big, thinking forward, we want to keep the knowledge and all the work that has been done after data pooling. So a couple of years ago, we worked with the IARC to establish our data coordination center to try to work more centrally. So far, the work has been done more, from each site. So we're working with a data coordination center at IARC, and actually, Children with Cancer is also helping to support a little bit of that effort. So thanks again for that. We're also very cognizant of possibility of bias, recall bias, selection selection bias. So we are introducing more and more work in terms of method to see how much variation we have in our findings should we account for these, potential issues. And of course, as you can see from the map, we have an underrepresentation of some continents. And the way CLIC has worked so far is that we have reached out to people we know. Some people reach out to us, but we acknowledge it's not a comprehensive group of all the studies around the world. To address that, we try as much as possible to present the data from pooling the CLIC studies, but also meta-analysis from non-CLIC studies. So we can compare, should we have brought up in our analysis non-CLIC studies, what would be the impact? So we try to get around some of those challenges. Lesson learned, funding is really important. This is very crucial for the group to stay together. We have, every year we have a meeting. Everybody comes to the meeting, and we feel that it's really important to keep also the group alive in a sense, and people are always very happy to meet. And that helps to overcome the barriers of the language. Not everybody is speaking English fluently. This is not their native language. This is also helping to resolve issue in a very timely fashion. There's so many times you can do a conference call with so many different zone for the time. So meeting once a year does matter. And what we learn is that we need to be flexible. Because again, people are doing this pretty much on their spare time. So we've learned that from the start, you have an idea to the paper being published, it can take on average 4 years. It sounds daunting, but at least now we have a process, and we hope to reduce this time because we want to put out there, findings in a very timely fashion so we can be efficient. And again, to include junior investigators is very important. So now that we have established our structure for childhood leukemia studies, we actually are expanding to other cancers, embryonal tumors and brain tumors, and we hope to become the global epidemiology for childhood cancer group. So this is a work in progress, but things should be should be easier because we already have the structure in place and the group. This is our group, and you're welcome to contact us if you would like to join. We'll be happy to talk to you. I would like to turn now my last part of the talk to other work that I'm doing through the Center for Integrative Research on Childhood Leukemia and the Environment. Again, as much as the CLIC consortium is bringing a lot of findings and helps us to be confident, I think there is some limitation. Most of it is relying on interview data, and therefore we cannot really nail down with more precision exposure to certain chemical. So our group here that we call Circle has worked, again, not only with the CLIC consortium, but has tried to improve exposure assessment to get more precise risk estimate and to bring in more genetic and epigenetic work. That was the first phase of our center. And since then, we also have brought research that tries to better understand some of the mechanistic pathway that could be involved in childhood leukemia, and those are around immune function. So this is a very complex group, but the idea is to really work together and to merge the expertise from toxicologists, exposure assessment biologists, geneticists, nutrition epidemiologists. A lot of different people that can work together to get maybe to a better understanding of mechanistic pathways. We are working with an existing study here in California that started maybe actually 15 plus years ago, and for which we had more controls in terms of collecting data, and to go beyond the interview of the parents, which I mentioned was the primary source of information for the CLIC consortium. We also are trying to improve our exposure assessment by collecting a residential history from birth to a diagnosis. But also, we've done something that was quite special and unique, was to go back to the homes of families who had a child that was diagnosed with leukemia and healthy control. And I will present a little bit more of this data, but that was a very unique way to understand what is the cumulative exposure to chemical in the homes, and with a more objective understanding of what are those chemicals. And of course, we are trying to work with biomarkers, but of course in the context of case control studies, this is challenging because we have to go back in time. And what can we say when we don't have a large number of children that we can follow and wait for the outcome to arrive? So we're working with the issue of temporality, but luckily we have access to a lot of different biospecimens, and in California we have access to Guthrie cards, which are blood spots that are collected at birth in order to diagnose metabolic syndromes that could be treated right away. And in California, those blood spots are being made available through research, so we can actually use that to really explore the in utero exposure. So let me move on to dust, because I think this is a very interesting work. Why dust? Children are spending most of their time at home, and they have more opportunity to be exposed through ingestion or skin exposure to the skin. So we believe that this is a very important route of exposure. So working with the National Cancer Institute, we've collected dust in 500 homes and measured about 50 chemicals, and we were able to find excess risk of childhood ALL with herbicide, PCBs, PHS, and flame retardants. We found no association with metals, for example, or another, other type of insecticide. But we were able to identify exposure to very specific chemicals that no interview could be helpful with. We had an issue in California in terms of flame retardant. There was a law that started maybe 15 years ago when it was mandatory to add a flame retardant in the furnitures. So we have one of the highest level of flame retardant in the world. Fortunately, the law has reversed, and it's not mandatory anymore. But still, the impact is there. Those are persistent chemicals, and when we measured those chemicals in the homes of the families in our study, we found that, for example, the families that had old furnitures, which are higher opportunity to release those chemicals, were the one for which we were measuring the highest rate of flame retardant. So this is a real problem in California. This is where the consortium cannot really help resolve some local issues, so you still have to do your work, in your region to address, specific exposures. And we found, of course, when we compare the level of a flame retardant in the dust to the blood levels in the mom and the child, we find that there is a linear relationship. The higher level of flame retardant in the dust, the higher burden, body burden in the child and in the mom, and we did find excess risk of childhood leukemia with higher risk of flame retardant. So this is really unique to our study. Nobody has replicated that, although I would encourage people to do so, but this is still something that is very robust, because we are able to work through a different media and measure those chemicals in different ways. This is another example of what we have done in the dust. We have measured pretty much all those compounds here. And in California, about 40% of our children are from Latino descent. And I will show you tomorrow that Latino children in California and in the United States have the highest rate of childhood leukemia. When we measure dust, people will say, well, you measure this after the fact, after the child had leukemia. how can you rely on this? So what we did, we actually went back and measured to collect dust like 2 to 5 years after the first dust collection to see how much difference we had over the, that period of time. And what we can see is that for those persistent compounds like PCBs, you see it was between the round 1 and 2 of dust sampling, it was fairly consistent. So whatever we find in the dust is a good reflection of what happened 5 years, 7 years possibly. So I think this is also telling that those chemicals are persistent and we can measure them, and we're able to find that some of them are associated with increased risk of childhood leukemia. Finally, I just wanted to draw your attention to work that we're doing in our center, is that not only we are doing the research, but we want to make sure that our findings are getting out. And we're working with my colleague Mark Miller here, who has helped us to reach out to different audiences, being the physician, being the public sectors, being the families, to help understand what can be done, what do we know already, and how can we prevent leukemia.